Hello, this is Miss Roberts. We're going to be discussing Chapter 17 in your Davis book, Caring for the Child with a Cardiovascular Condition. This starts on page 552 in your book. So it starts talking about the review of the anatomy, of course, the chambers and the valves. This is our chambers over here. So we have the right and left atrium and the right and left ventricle. And then we have our valves, which is our tricuspid, pulmonary, mitral, aortic. So there's a little acronym I use to remember those. Tissue paper, my assets. Okay? TPMA in that order. So the right valves and then the left valves. Okay? These are the vessels of the heart, and all of this is in your book. These are on page 554 and 555. So the superior and inferior vena cavas, and you have your aorta, pulmonary artery, pulmonary veins, and your descending aorta. Okay, and this is the normal blood flow. So from the body, okay, to the right atrium, through the right ventricle, up through the pulmonary artery, and into the lungs, from the lungs down into the left atrium, then the left atrium, left ventricle, back up into the aorta, and then down into the body. Okay, so just remember that blood flow. On page 554, it talks about different syndromes of the cardiac associated with cardiac disease in children. So we have anything from Marfan syndrome, trisomy 18, trisomy 13, fetal alcohol syndrome, the Vader-Turner syndrome, several of them. Okay, Down syndrome is a big one. Then it starts talking about on 555 the different, and there's your chambers, the different cardiac output and stroke volume. So if you need a refresher, there's those terms. Make sure you understand those. On page 556, we're going to talk about congestive heart failure. I'm not spending a whole lot of time on this with pediatrics because it is rare, very rare. If you go into cardiac ped specialty, by all means, you're going to learn all kind of things about it, but we're not going to spend a whole lot of time on this. So CHF in a child, poor feeding, poor growth, irritability, puffy eyes, excessive sweating, of course bulging fontanelles because they have that ICP, right? But one thing I do want you to know, and that's up here, wink and lollipop, is is the congestion. Understand the congestion. How does it happen? Okay. So it moves backwards. Okay. Characterized by inability of the heart muscle to function properly and move the blood forward. So it gets congested by moving kind of in a backwards direction, so to speak, just not pumping out as it should. Okay. It backs up in the other areas, lungs, liver, and then fills into the periphery. Okay, so that's why we have edema with CHF. Okay, everything kind of backs up. Then you start having different types of cardiac diseases, such as cardiomyopathy and Kawasaki's disease, and this leads to CHF. And we'll talk more about Kawasaki's disease. Medical care, on page 557, talks about what do we do? What do we do for this? So you have positive inotropes and increased preloads. We use a drug called captopril. Okay, important for you to know. Wink and lollipop. All right. It's a prill, so what does that make it? An ACE inhibitor. Alright, furosemide, Lasix is another one, but know that captopril, okay? It's a vasodilator. We're trying to increase that afterload, okay? There's some more information on heart failure. Common medications used are on page 561. And you remember some of these, the beta blockers, right? The laws. The pines or pines are calcium channel blockers. The ides are diuretics. The prills are ACEs, and the ARBs are ARTANs or ARBs. Okay, so just a good review right there. But you need to know those ACE inhibitors, captopril, like we just talked about here, Capitan is captopril. Okay. On page 561, let's go there, and there's the same chart over here. Okay. The medical care, it talks about the Coreg. Okay. So another Winking lollipop. No, these drugs that manage this congenital heart disease. Okay, so carvedilol is Coreg, and LOL is a beta blocker, right? It's a contractile agent that helps the contractions of the heart. Okay. Now we're going to talk about defects. Some congenital heart defects on page 562. So our first one is ASD, atrial septal defects. And I have divided those up into acyanotic and cyanotic. And we know what cyanotic means, right? The blood is not perfused with oxygen, and they are divided up into different groups. So we have some defects over here for acyanotic, and then we have some for cyanotic. So we're going to talk about the acyanotic first. Atrial septal defect is an acyanotic defect, okay? So this is a defect with the atrium, and I've got some handouts I'm going to give you. So this is open, okay? There's significant number that this happens to, but this is the left and right shunt, okay? If it does not close after birth, it becomes that atrial septal defect. So in the atrium, the septum has a defect, okay? So it's real easy to remember. Remember, atrial, the atrial wall, the septum between the atriums has a defect, stays open, okay? Let's talk about page 564, the ventricular septal defect. So, as you can imagine, where is that defect? In the ventricle septal wall, okay? It has a hole or stays open, kind of like Swiss cheese, has that hole, okay? And again, it's an acyanotic defect. And you have PDA, patent ductus arteriosus, okay? So, this is when their pulmonary resistance is higher than the left-sided pressures, okay? It forces the blood into the right side through that PDA, and eventually it should close because the fetus does not use the lungs in utero, right? They're getting all the oxygen and nutrients they need through the umbilical cord. So this PDA is open. But at birth and within a few hours after birth, this closes. That ductus arteriosus should close. This is when you may hear a murmur And then you call the doctor. Yes, I heard a murmur. Can you come in and see if you hear the murmur? And by the time they get there, they're like, oh, I don't know what you're talking about. It's not there. I don't hear a murmur. When you're 100% sure you heard a murmur, well, that just means the PDA has closed. That happens very often. They would probably still want to run an echo just for certain, but that does happen, okay? They will go in and close it with a transcatheter device, but they can also use a drug, and that's called Indocin, okay? It closes the PDA, okay? They put that in the baby, and it acts and closes that PDA. So winking lollipop right here, okay? There are congenital heart defect videos that I want you to watch on Blackboard. Make sure you pull those up. I will actually email you those videos as well. Sometimes from semester to semester they don't go over on Blackboard as they should, but I'll email them to you as well, so make sure you pull those up. Make myself a note. Alright, so let's talk about obstructive lesions on page 567. So we have the coarctation of the aorta. Now that's a narrowing or stricture-like defect that happens right here. You can see that where it's pointing, okay? And it's in the distal portion of the carotid artery, okay? Preductal, ductal, and postductal is how it's classified. Normally in the blood pressure in the lower extremities is higher. Or is lower, okay? So if the blood pressure in the lower extremities is lower than the upper extremities, there may be a heart defect. That's why we do the CCHD, which is the cardiac congenital heart defect test, where we check the blood pressure like on the right lower leg and the upper left arm. We're looking for these types of defects, and every baby that goes home is discharged from the hospital should have that check done. We check O2 sats and we check blood pressures. So that's why we do that, because it's not flowing as it should, okay? Sometimes you can hear a murmur, sometimes you won't. That's why it's so important to auscultate that heart, that apical pulse for 1 full minute, okay? You need to watch for labored breathing related to oxygen and perfusion, but this whole section here is a winking lollipop, okay? You need to understand this, okay? And then you need to understand these signs and symptoms. Another winking lollipop, okay? All of this is winks and lollipops, okay? So what did I say? Auscultate for murmurs, right? Auscultate for the murmur. And then observe for labor breathing related to oxygenation and perfusion. Make sure you understand the difference in the pressure measurements between the arms and the legs, as we talked about, okay? Pulmonic stenosis. This is a malformation in the pulmonary artery or the pulmonary valve, okay? And this shows here. Read through this here, and then you'll see the pulmonic stenosis. One of those has a defect, okay? Signs and symptoms, of course, will be a murmur, grade 2 to 4 out of 6. Well, sometimes you'll hear that click on ejection, okay? And that's pulmonic stenosis. And of course, we confirm that with an echo, right? ECG. All right, so that's it for the acyanotic defects. Let's talk about the cyanotic defects now. It talks about aortic stenosis too on 568, but we're going to go on to 569. Cyanotic congenital heart defects. So tricuspid atresia, TA, is mentioned here. It's a single defect, incompatible with life. There's no blood from the right atrium to the right ventricle, and there's no output to the pulmonary artery and the lungs. So the infants cannot live with a tricuspid atresia. Okay, the signs are very, very dramatic. We can lollipop. Okay, when that PDA starts to close, they're not making it. Okay, so it's hard to figure out what's going on because the PDA is what's keeping them alive. The opening between that ductus arteriosus, that patent ductus arteriosus, is what's keeping them alive. You can generally hear a heart murmur on the left sternal border. So that's why it's so important to be trained knowing how to hear murmurs, because you could save this infant's life by trying to keep that PDA open. Clinical signs appear early following birth, and they are not corrected with supplemental oxygen. So you might want to write that down. For this cyanotic heart disease or any cyanotic heart disease, the clinical signs, number one, winks and lollipops, number one, for cyanotic heart disease, clinical signs appear early following birth, okay? And they are not corrected with supplemental O2. This tricuspid atresia is an emergency, obviously, right? They're given the PGE1 to keep that PDA from closing. So if you hear a murmur and you start seeing the signs and symptoms of them getting blue, cyanotic, right? You're notifying the pediatrician immediately. They're ordering that PGE1, and that's going to keep that PDA from closing until surgery can happen. All right. So just make sure you read through this. Then they'll have the Glenn procedure done, and then the Fontan is the definitive surgery. Okay. Pulmonary atresia. It's a fatal defect if not corrected as well, and they can give that PGE1 there as well. So this is our acyanotics. Pulmonary, the PDA. And remember, this is what's keeping this tricuspid atresia baby alive. And the coarctation here, so that narrowing. Pulmonary stenosis, you have that tight valve, okay, and then the cyanotic. So this is tricuspid atresia. It cannot flow. And then the pulmonary atresia, okay. Stenotic dilatation, stenotic valve, and you see the stenotic part right here. You see it? See how that valve is just, it's almost hard. Okay, it's not loose and opening and closing. Okay. All right. So let's look on page 571. We're going to talk about trunctus arteriosus. And that's the Epstein's malformation. You can read about that in your book. Clonal trunctal defects. And then trunctus arteriosus. Okay, so this is when you have just only one large vessel coming out of the heart instead of two. All right. Let's see if I can go back up and find that picture here. Okay, so there's only one coming out instead of two. So you should have two, right? But there's only one. So make sure you read that. This is, they turn blue, they have congestive heart failure, low cardiac output, and of course you're going to hear that murmur on ejection, okay? Most of the time. They'll have clubbing in their fingers and toes because of the low O2 sats that they are living with. Tetralogy of Fallot, not Fallot, tetralogy of Fallot, okay? Tetra, it means four, right? Important to know. Tetralogy of Fallot. This means there's four things wrong with the heart, okay? There's four abnormalities. So the first one, pulmonary stenosis. The second one, right ventricular hypertrophy. The third, overriding aorta. And the fourth, ventral septal defect. Some signs and symptoms are tachypnea, dyspnea, growth failure, cyanosis, a loud, harsh, radiating murmur, and then of course the hypertrophy, because they have that stenotic vessel and there's high pressure. So remember, always the louder the murmur, the smaller the hole. The softer the murmur, the larger the hole. Okay? So they have a loud murmur. That means it's a small hole. These are our TETS babies. They have what we call TETS spells, winks and lollipops here. They have this, the telltale sign of TOF, tetralogy of Fallot, is them having those TETS spells. They get excited, they start crying, and then they become cyanotic. Okay, with the crying or playing, they can pass out. They relieve this by drawing up their legs or squatting. Okay, that gets the heart back to the blood, the blood back to the heart by decreasing how far it has to go. They think squatting down is helping that. It's increase in mixed blood leaving the heart and circulation, so deoxygenated blood is going back into the peripheral system. In a hospital setting, we can do other measures like lowering the heart rate, including giving them morphine, putting them in a knee chest position. But I'll have to tell you a story about a boy that I knew that succumbed to tetralogy of Fallot. Very, very sad situation. Let's make sure you understand that. Winks and lollipops, okay? Then let's look on page 573, and it's talking about the classification of murmurs, all right? This is the hypoplastic heart disease. You can read through that, and that's our PGE1 again that's given to keep that PDA open that's used. It's just a prostaglandin, okay? So just understand that. Alright, and then our classification of murmurs. Okay, so aortic, pulmonic, mitral, and tricuspid, and these are the different effects. And then our classification numbers here. Okay, so number 1 is soft, number 2 quiet, number 3 a little bit louder, number 4 really loud, number 5 very loud. And number 6, you can hear it without a stethoscope. You can just hear it on the outside. It's very, very loud. You have a case study here that you need to do to put this all together. Now let's talk about some cardiac diseases. The first one is subacute bacterial endocarditis. Okay, fever, itis, we know what? Inflammation. Okay, it's infection in the bloodstream. Very, very bad. Loss of appetite, high fever. So, know these signs and symptoms, winks and lollipops, okay? Fever, chills, sweating, back pain, swollen joints, stiff joints. Just know that it is of course, bacterial infection, okay? All right, Kawasaki disease. And this is transposition of the great vessels. You can read about that too. And the hypoblastic, and then the murmurs. And we'll listen to the murmur video in class. All right, endocarditis, what we just talked about, high fever. It damages that bacteria growth, damages those vessels, okay, and those valves, okay. And you can see this damaged valve here. Kawasaki disease. I've had students come back and tell me that they remember my picture of a motorcycle over the heart. To remember, Kawasaki disease is not an integumentary disease. It's a cardiac disease, okay? It's known as mucocutaneous lymph node syndrome. It affects multi-systems, but mainly affects the cardiovascular system, okay? Winks and lollipops. It's more affected on Japanese children, and it's more prevalent in the winter and the spring, okay? It is, really doesn't know why they get it, but it is a defective immune response to infectious diseases. So they're very irritable. They have some conjunctivitis, a strawberry tongue, a rash, a fever. So this is Kawasaki disease. All right, it's acute systemic inflammation of those blood vessels. And there's that rash, okay, palmar rash, and then the strawberry tongue. All right, let's look at cardiomyopathy on page 575. It's when the cardiac muscles become hypertrophied, dilated, okay? Make sure you read through that, understand that. One thing I want you to remember about the cardiomyopathy in children is they get short of breath, okay? They get short of breath, and they are poor feeders, all right? Because of that hypertrophy or stiff muscles, okay? Their heart is not contracting as it should because that myocardium is damaged, resulting from some type of toxins, okay? The atrias are what's enlarged and impairs the filling because of the stiffness of those ventricles. So because the ventricles are stiff at the bottom of the heart, it flows back into the atrium, and the atrium becomes enlarged, okay? And so they are short of breath and poor feeding. So remember that wink and lollipop, okay? Let's look on page 577. And it's talking about detecting rheumatic fever, which is important. Nursing insight. Okay, so rheumatic fever. Remember, we talked about the pharyngitis when I was talking about that with the previous chapter. So this is a heart condition that can be caused by a sore throat. Okay, that's why it's so important that they finish the antibiotics. All right. So Winks and Lollipops, you need to know this section all about what happens. Okay, they have a elevated ESR, elevated C-reactive protein, but what happens is they start out with acute pharyngitis. Okay, they start out with a sore throat, acute pharyngitis. It's always 5 to 15-year-old children usually. Okay, 2 to 3 weeks after the infection, the organism invades the bloodstream and makes deposits on the valves of the heart. Kind of sits there in a vegetative state, causing permanent damage. Okay, it's the aortic and mitral valves that are most frequently involved. Okay, rheumatic fever is always coupled with strep throat. Okay, so make sure you understand what happens right here. Acute pharyngitis is very contagious. They get that, and then that bacteria settles down onto the valves of the heart, causing rheumatic fever. Alright, so there's a lot of extra stuff in this chapter that you cover, cardiac stuff in Med-Surg that I'm not going over. I will mention one thing on page 8 on 583. Cardiac caths don't really happen a whole lot with children, right? But there's one thing I want you to remember. Under collaborative care, it says the child can be placed on telemetry for dysrhythmias, of course, after the cardiac cath is done, because arrhythmias may be induced from the catheter. Okay, so we need to be watching for any type of arrhythmia or dysrhythmia that was induced because of the catheterization. Okay, doesn't happen, and that's with anybody with a heart cath. Okay. And this talks a little bit about that over there. All right, that is it for chapter 17.